Welcome to the deep dive, where we take your stack of sources and really pull out the key nuggets of knowledge. Today, we're diving into something fascinating, truly essential. The thyroid gland. It's, pretty small physically, but as we'll see, its influence is massive, conducting this whole symphony of functions across your body. Our mission today is simple. Go deep. We want to unpack everything about the thyroid. We'll look at its structure, right down to the cells, how it makes these powerful hormones, how that's all kept in balance, and crucially, what happens when that balance is lost. The goal here is for you to walk away with a really solid professional level grasp of this vital bit of physiology. We're drawing heavily from a comprehensive physiology text for this one.
Okay.
Okay, so let's start with the basics. Where exactly is this gland and, what's it look like?
Right. It's situated low down on the front of your neck, kind of just above where your collarbones meet. It's often described as butterfly shaped, which is a pretty good visual. It has these two main parts, the right and left lobes, sitting on either side of your windpipe, the trachea.
And usually there's a little strip of tissue connecting them in the middle called the isthmus. Now, being such a busy organ, it needs a really good blood supply. Lots of vessels going in and out, bringing fuel, taking away hormones. It does have nerves too, but they're mainly for controlling that blood flow, not really for telling it when to release hormones directly. Okay, so that's the big picture. Let's zoom way in now, down to the microscopic level. What's the actual workhorse here?
The core functional unit, the sort of mini factory, is called the thyroid follicle. Picture these tiny spherical structures like little bubbles, hundreds of thousands of them. Each one is lined by a single layer of specialized thyroid cells, the epithelial cells. These cells sit on an outer membrane, and they're surrounded by this dense network of tiny blood vessels, capillaries, ready to whisk hormones away. And the inside of that bubble, the central space, that's filled with this gel-like stuff called colloid.
Right, and that colloid is mostly made up of a very large, complex protein called thyroglobulin. You can think of thyroglobulin as like a scaffold or maybe a backbone just waiting to be iodinated, basically decorated with iodine atoms by those surrounding cells. That's how the actual hormones get built. What's really cool is how dynamic it is. The size of those cells and the amount of colloids stored inside, that changes depending on how active the gland is at any given moment.
Exactly. So that follicle, it's not just a static structure. It's this incredibly efficient, self-contained unit. It's perfectly designed for both making the hormones and storing them right there.
Right.
A little factory and warehouse combined. It's really a masterclass in biological design, making sure your body has hormones ready when needed.
A mini factory and warehouse, I like that. So what are the actual products coming out of this factory? What hormones are we talking about?
We're talking about iodothionines. That's the chemical class. They're formed by coupling together two molecules derived from the amino acid tyrosine.
Mm-hmm.
But critically, they contain iodine.
Okay, iodothionins, and the main ones.
The major player, making up about 90% of what the thyroid secretes, is tetraiodоthionine. We usually just call it T4 or sometimes Cerox.
T4, got it, 90%.
Right. But interestingly, T4 mostly acts as a prohormone, meaning it's like a precursor. It needs to be activated later elsewhere in the body to really exert its full effects.
Oh, okay. So what's the active form then?
That would be triiodоthionine, or T3. It only makes up about 10% of what the thyroid directly secretes. But, and this is key, a lot of the body's active T3 is actually generated later by converting T4 in peripheral tissues, like your liver, kidneys, even the brain.
So the thyroid makes mostly T4, but T3 is the one doing most of the heavy lifting, and a lot of T3 comes from converting T4 later on.
You got it. And the absolute non-negotiable requirement for making both T4 and T3?
Iodine.
Iodine. Without it, none of this happens.
Which brings us neatly to this crucial ingredient, iodine. It really is the unsung hero here, isn't it?
Absolutely unique role. Essential.
So how much do we actually need? Is it a lot?
Surprisingly little, actually. For adults, the minimum daily requirement is only about 150 micrograms.
Micrograms, that's tiny.
It is. Think much, much less than a grain of salt. Children need a bit less, maybe 90 to 120 micrograms. Pregnant women, though, need more, around 200 micrograms daily. That's because thyroid hormone is absolutely critical for the baby's brain development.
Okay. And what's typical intake, say, in the U.S.?
Average intake here tends to be higher, around 400 micrograms daily, largely due to things like iodized salt and certain foods.
And in a balanced state, what goes in comes out?
Pretty much. In steady state, that same 400 micrograms is typically excreted in the urine. But the body is clever about handling it first. It actively concentrates iodide, pulls it in.
Primarily in the thyroid, obviously.
Yes, but also in other places, which is interesting. Salivary glands, the stomach lining, tear glands, mammary glands during lactation, even parts of the brain called the choroid plexus.
Huh. Okay, so how much does the thyroid itself grab daily?
From that circulating pool, the thyroid actively takes up about 70 to 80 micrograms of iodide each day.
And how much is stored inside the thyroid?
That's where it gets impressive. The total amount of iodide stored within the thyroid averages around 7,500 micrograms.
Wow, okay, that's a lot compared to the daily uptake.
Exactly. And almost all of that stored iodide is already incorporated into thyroglobulin, sitting in that colloid we mentioned. So in that steady state, only about 1% of the total stored amount, roughly 70 to 80 micrograms of iodide, is released daily. Most of that leaves as T4 and T3, and a little bit escapes as free iodide, which can be recaptured.
So that huge storage ratio, like 100 to 1 stored versus daily turnover, that's a safety net, right?
Right, precisely. It provides a buffer. It means your body can weather a period of low iodine intake for potentially up to 2 months before serious problems arise.
And there's another backup.
Yes, the kidneys play a role too. If your blood iodide levels start to fall, your kidneys get the signal to drastically cut back on how much iodide they excrete in urine. It's another conservation mechanism.
Very clever. The body really holds on to that iodine tightly.
It has to. It's that essential. Which raises the question, how does the thyroid actually do all this? How does it trap the iodine and build these hormones step by step?
Right, let's trace that assembly line. It's quite a journey for the iodine atom.
It is. And it's very directional within those thyroid follicle cells.
So the two key ingredients, again, are iodide, coming from the blood, and that big thyroglobulin protein made by the cell.
Correct. Iodide needs to be moved from the blood side, the basal side of the cell, all the way across to the apical side, facing the follicle lumen, that colloid space. Meanwhile, thyroglobulin is made inside the cell and secreted directly into that same lumen.
And the actual hormone building happens in the lumen.
Yes, enzymatically, right near the cell surface in the colloid.
Okay, let's break it down.
Step 1, getting the iodide into the gland. The iodide trap.
Right. This isn't passive diffusion. Iodide is actively pumped into the thyroid cell. It's moved against both its chemical concentration gradient and the cell's electrical gradient. Requires energy.
So a specific pump is involved.
Exactly. It's called the sodium iodide symporter, or NIS. It sits in the basolateral membrane, the blood-facing side of the thyroid cells.
It cleverly uses the energy from sodium wanting to rush into the cell to pull iodide in alongside it. It's a secondary active transport mechanism, ultimately powered by the cell's main sodium-potassium pump.
And this NIS pump can ramp up its activity.
Massively. If your dietary iodide intake drops, the activity of this trap increases dramatically. The thyroid can end up grabbing 80% or even 90% of the iodide circulating in your blood. It's desperate to get enough.
Wow. Okay, so iodide is trapped inside the cell. Step 2.
Step 2 is moving it across the cell into the follicle lumen. Once inside the cell, iodide quickly travels to the apical membrane, the side facing the colloid, and there, another transporter called pendrin moves it out into the lumen. This one doesn't depend on sodium.
Okay, pendrin. So now iodide is in the colloid next to the thyroglobulin. Step 3.
Step 3, iodination. As soon as iodide enters the lumen, it's rapidly oxidized by an enzyme called thyroid peroxidase, or TPO. This oxidized iodine is then immediately attached to specific tyrosine residues within that big thyroglobulin protein scaffold.
Attaching iodine to thyroglobulin.
Right? If one iodine atom attaches to a tyrosine, it forms monoiotyrosine, or MIT. If a second iodine attaches to that same tyrosine, it forms deiodinases, or DIT.
MIT and DIT. Got it. These are the building blocks.
Exactly, which leads to the final step. Step 4, coupling. This is where T4 and T3 are actually formed, still catalyzed by that TPO enzyme. Two DIT molecules link together to form T4. Tetra means 4 iodines. Or one MIT and one DIT link together to form T3. Tri means 3 iodines.
And this linking happens while they're still attached to the thyroglobulin.
Precisely. The coupling occurs between iodidated tyrosines still embedded within the thyroglobulin backbone.
Clever. And you mentioned earlier something about favoring T3 production when iodine is scarce.
Yes, that's a really smart adaptation. When iodide availability is limited, the enzymatic process tends to favor the coupling that forms T3. Since T3 is the more potent active hormone, this gives the body more bang for its buck, more hormonal activity per molecule of scarce iodine.
Makes sense. And does T3 production also increase when the gland is just generally working harder?
It does. If the thyroid is being strongly stimulated, for instance by TSH, the proportion of T3 produced also tends to increase.
Okay, so the assembly line is complete. T4 and T3 are built, hanging onto the thyroglobulin scaffold in the colloid. How do they get out?
Right, they're stored there in the colloid until the body signals it needs them.
So release starts with taking that colloid back into the cell.
Exactly. The process is called endocytosis. The thyroid cell membrane reaches out and engulfs little droplets of colloid from the lumen. Think of it like the cell drinking the colloid.
Okay, so now these little packets of colloid are inside the cell.
These packets, or vesicles, then fuse with lysosomes. Lysosomes are like the cell's recycling centers, filled with digestive enzymes.
Ah, so the thyroglobulin gets broken down.
Correct. Lysosomal enzymes chop up the thyroglobulin protein backbone. And this enzymatic digestion is what finally liberates the T4 and T3 molecules.
Freeing them up to leave the cell. But what about the leftover bits, the MIT and DIT?
Here's where that incredible efficiency comes in again. The MIT and DIT molecules, also released during this breakdown, don't just get wasted. There's another enzyme inside the cell called iodotyrosine deiodinase that specifically targets MIT and DIT.
And it does what?
It strips the iodine atoms off them. This enzyme is specific. It doesn't work on T4 or T3.
So the iodine gets recycled?
Precisely. The freed iodide goes right back into the cell's iodide pool, ready to be used again to synthesize new hormones. It's a fantastic conservation strategy.
And the amino acids from the thyroglobulin.
They also get recycled, re-entering the cell's general pool to build new proteins. Very little intact thyroglobulin actually escapes the cell normally.
Okay, so T4 and T3 are now free inside the cell. How do they get into the blood?
They're transported across the basal side of the cell, the side facing the capillaries. It's likely via specific transporter proteins, though the exact ones aren't fully pinned down. And then finally, they enter the bloodstream.
That recycling is amazing. It really highlights how the body avoids wasting that crucial iodine.
It's a beautiful example of biological resourcefulness. Nothing goes to waste if it can be reused.
Okay, so T4 and T3 are now officially launched into the bloodstream. Mission accomplished.
Well, getting them made and secreted is only part of the story. Now they have to travel, and then they have to get into the target cells where they actually do their work.
Ah, right. How do they travel? Do they just float freely?
Almost none of it floats freely. Over 99.5% of the T4 and T3 circulating in your blood is bound to specific transport proteins.
99.5%, so only a tiny fraction is unbound.
Exactly. Only about 0.03% of the total T4, about 0.3% of the total T3 exist in that free, unbound state. And it's that tiny fraction of free T3 that is actually biologically active. That's what interacts with cells, mediates effects, and provides the feedback signal to the brain.
Wow. Okay. So what are these transport proteins?
There are a few main ones. The most important is thyroxine-binding globulin, or TBG. It's made in the liver and binds about 70% of the circulating T4 and T3.
TBG. So changes in TBG levels would affect total hormone measurements.
Significantly. If your TBG levels go up or down, your total T4 and T3 levels will change, even if the active free levels and your actual thyroid status are normal. That's an important clinical point.
Got it. What else carries them?
There's also transthyretin, or TTR, which carries about 10–15%. TTR is particularly important for transporting T4 across the blood-brain barrier into the cerebrospinal fluid. And then albumin, the most abundant protein in plasma, carries about 15–20%. A tiny bit binds to lipoproteins, too.
So TBG is the main carrier. Does binding to these proteins do anything else useful?
Yes, a couple of key things. First, TBG acts as a large circulating reservoir for T4. This buffers any sudden short-term fluctuations in thyroid gland output, ensuring a more stable supply to the tissues.
Like a reserve tank.
Exactly. And second, binding to these large proteins prevents the relatively small T4 and T3 molecules from being filtered out by the kidneys and lost in the urine. So that, again, it helps conserve that precious iodide.
Makes sense. Okay, so they travel bound up. How do they get into the target cells? Do they just slip through the cell membrane?
That was the old thinking, but we now know that's not the case. Thyroid hormones generally need help. They require specific transporter proteins embedded in the cell membranes to facilitate their entry. It's not simple diffusion for the most part.
More transporters. So getting hormones into cells is also a regulated step.
Very much so. There are actually many different types of these transporters, maybe 20 or more, belonging to different gene families. Some well-known examples are the monocarboxylate transporters, specifically MCT8 and MCT10. They can transport both T4 and T3 across the plasma membrane.
MCT8, MCT10, are they clinically important?
MCT8 definitely is. Mutations in the gene for MCT8 cause a serious X-linked developmental disorder. It leads to things like high T3 levels in the blood, muscle problems, and severe neurological and intellectual impairment. It really highlights how crucial this transport step is.
Wow, okay, so just getting the hormone near the cell isn't enough, it has to get in.
Precisely. Another transporter, OATP1C1, seems important for getting T4 across the blood-brain barrier specifically. The exact roles and tissue distribution of all the other transporters are still areas of active research. It's complex.
Yeah, it sounds like delivery is just as tightly controlled as production.
It has to be. Ensures the right amount gets to the right place at the right time. A malfunction anywhere in the chain, from synthesis to transport to cellular entry, can cause significant problems.
Okay, so assuming the hormone gets into the cell, we talked about T4 being mostly a prohormone and T3 being the active one. How does that activation happen?
That's where another set of crucial enzymes comes in, the deiodinases. Since the thyroid mainly pumps out T4, but T3 does most of the work, the body relies heavily on these deiodinases in peripheral tissues to convert T4 into T3.
Peripheral conversion, okay. Are all deiodinases the same?
No, there are different types, and they vary quite a bit in where they're found, what they prefer to work on, how strongly they bind, even where they are located within the cell.
Let's break them down. What's the first type?
Top 1 deiodinase, or D1. Its main job is converting T4 to T3 by removing an iodine atom from the outer ring of the molecule. It has a relatively low affinity for T4, meaning it works best when T4 levels are fairly high. You find D1 mainly at the plasma membrane, in the liver and kidneys, large organs with lots of blood flow.
So D1 contributes mostly to the T3 circulating in the blood.
Exactly. It makes T3 available for uptake by other tissues throughout the body.
Okay, D1. What's type 2?
Type 2 deiodinase, or D2. This one also converts T4 to T3, but it's different in key ways. First, it has a very high affinity for T4, meaning it's very efficient even when T4 levels are low. Second, it's located inside the cell, primarily on the endoplasmic reticulum membrane, not the outer plasma membrane.
High affinity, intracellular. Where's D2 found?
It's expressed in specific critical tissues: the brain, central nervous system, the anterior pituitary gland, and brown adipose tissue, brown fat.
Pituitary and brain. That sounds important for regulation.
Extremely. The presence of D2 allows these tissues to locally generate their own T3 supply from circulating T4, essentially customizing their intracellular T3 levels independently of what's floating around in the blood.
So the brain can make sure it has enough T3 even if blood levels fluctuate.
Precisely. The brain, thanks to D2 and glial cells, can maintain pretty constant T3 levels even if circulating T4 starts to drop. In fact, D2 expression actually increases during hypothyroidism, trying to compensate by making more T3 locally.
And its role in the pituitary.
D2 is absolutely key for the negative feedback loop. Pituitary cells use D2 to convert incoming T4 into T3 intracellularly. That intracellular T3 then acts to suppress TSH secretion. It allows the pituitary to sense and respond to the total pool of available thyroid hormone, both T4 and T3.
Fascinating. So D2 is critical for local control and system-wide feedback. Does it contribute to circulating P3 at all?
Yes. Despite being intracellular, D2 activity actually provides most of the T3 found circulating in the blood under normal conditions.
Really? More than D1?
Current understanding suggests yes, D2 is the major contributor to circulating T3.
Okay. So D1 and D2 make active T3. Is there an off switch?
Yes, that's the job of type 3 deiodinase, or D3. D3 is the primary inactivating deiodinase. It removes an iodine atom from the inner ring of T4, converting it to an inactive form called reverse T3, RT3. It can also inactivate T3 itself.
So D3 gets rid of excess active hormone or precursor.
Essentially, yes. D3 activity increases during hyperthyroidism, acting as a protective mechanism to help blunt the overproduction of active hormone. It also increases significantly during severe illness, starvation, or major stress, a situation called non-thyroidal illness syndrome, NTIS, or euthyroid sick syndrome. This shift towards inactivation helps conserve energy during critical periods.
Right. We'll come back to NTIS. This whole deiodinase system adds another layer of complexity, doesn't it? It's not just about making T4 and T3, but actively managing their activation and inactivation throughout the body.
Absolutely. It allows for incredibly fine-tuned, tissue-specific regulation of thyroid hormone action.
And you mentioned some research about patients who don't feel well, even when TSH is normal on T4 replacement. Could that be related to deiodinases?
That's an active area of investigation. Some people hypothesize that genetic variations, polymorphisms in the deiodinase genes might affect how individuals convert T4 to T3, potentially explaining why some athyroid patients on standard T4 therapy still experience hypothyroid symptoms despite having a normal TSH level.
Interesting. So maybe treatment needs to be more personalized in the future based on individual deiodinase function.
It's a possibility being explored. It highlights that we're still learning the nuances of this system.
Okay, so we have production, transport, cellular entry, activation, inactivation. It's Incredibly complex. How does the body keep this entire system regulated and balanced day to day?
The master control system is the hypothalamic pituitary thyroid axis, or HPT axis, and it operates primarily via negative feedback.
Negative feedback, like a thermostat.
Exactly like a thermostat. Here's the chain of command. 1. The hypothalamus, part of your brain, releases thyrotropin-releasing hormone, TRH. 2. TRH travels a short distance to the anterior pituitary gland at the base of your brain and tells it to release thyroid-stimulating hormone, TSH. 3. TSH travels through the bloodstream to the thyroid gland and stimulates it to produce and release T4 and T3.
Okay, TRHH, TSH, Neri-Shanday, T4, T3, where does feedback come in?
The circulating levels of free T4 and especially free T3 act back on both the pituitary and the hypothalamus. High levels of T3 and T4, which gets converted to T3 inside the pituitary cells via D2, tell the pituitary to decrease its release of TSH. They also signal the hypothalamus to decrease its release of TRH.
So high thyroid hormone levels turn down the signals that stimulate the thyroid.
Precisely. It prevents levels from getting too high. Conversely, if thyroid hormone levels drop too low, the feedback inhibition lessens, TRH and TSH release increase, and the thyroid gets stimulated more.
Maintaining that balance. Is TSH secretion constant throughout the day?
It's relatively stable. There's a small natural increase during the night, but overall the feedback keeps PSH and therefore thyroid hormone secretion and plasma levels fairly constant, no major daily swings.
Okay, so that's the feedback loop. What does TSH actually do at the thyroid gland itself?
TSH is the primary stimulator of pretty much everything the thyroid does. When TSH binds to its receptor on the thyroid follicular cells, it stimulates all the key steps in hormone production. It boosts iodide uptake, the NIS pump. It increases iodination of thyroglobulin, TPO activity. It stimulates the coupling reaction, forming T4 and T3. And it promotes the endocytosis of colloid and the subsequent release of T4 and T3 from thyroglobulin.
So it hits every step of the production line.
Yes, and it also provides metabolic support, for example, making sure the cells have enough energy, NADPH, for the TPO enzyme to work.
Right.
Over the medium-term hours to days, TSH stimulates the synthesis of key proteins like NIS, thyroglobulin itself, and TPO. It upregulates the machinery.
And long term, does it affect growth?
Absolutely. Sustained TSH stimulation leads to hypertrophy, cells get bigger, and hyperplasia, cells divide and increase in number. Blood flow to the gland increases, capillaries proliferate. These growth effects are supported by local growth factors within the thyroid.
And if this goes on too long, that leads to a goiter.
Exactly. A noticeably enlarged thyroid gland is called a goiter, and the classic example is endemic goiter, caused by chronic iodine deficiency. Low iodine means low T4-T3, which means the pituitary keeps pumping out high levels of TSH trying to get the thyroid to work. The constant stimulation causes the gland to enlarge dramatically, even though it can't actually make enough hormone.
Makes sense. Is there any other regulation besides the HPT axis?
Yes, there's a fascinating intrinsic mechanism called autoregulation by iodide, also known as the Wolff-Chaikoff effect.
Iodide regulates itself. How does that work?
It's biphasic. At low to normal levels of iodide intake, the rate of hormone synthesis is pretty much directly proportional to how much iodide is available. More iodide, more hormone up to a point.
Okay, but what if you suddenly get a huge amount of iodide?
If iodide intake skyrockets, say above 2 milligrams per day, the very high concentration of iodide inside the thyroid gland paradoxically inhibits the activity of the TPO enzyme.
It shuts down hormone production.
Temporarily, yes. It blocks the iodination and coupling steps. That's the Wolff-Chaikoff effect.
Why would it do that? Seems counterintuitive.
It's thought to be a protective mechanism against producing a dangerous surge of thyroid hormone if you're suddenly exposed to a massive iodine load.
Does the thyroid stay shut down?
No, normally the gland adapts. This is called escape from the Wolff-Chaikoff effect. The adaptation involves downregulating the NIS transporter, the iodide trap. This reduces further iodide uptake. The intraglandular iodide concentration falls, TPO inhibition stops, and hormone synthesis resumes, usually within days to weeks.
So it's a temporary break. Can this adaptation fail?
Rarely, yes. In some individuals, the NIS downregulation doesn't happen properly, leading to prolonged inhibition of hormone synthesis by the high iodide, which can actually cause hypothyroidism.
Interesting. Has this effect been used medically?
Yes, the temporary suppression of hormone synthesis by giving large doses of iodide has been used therapeutically, for instance, to rapidly lower very high thyroid hormone levels in patients with severe hyperthyroidism, thyroid storm, buying time for other treatments to work.
Wow. So the HPT axis provides the main control, but the thyroid also has this internal iodide sensing safety brake.
Exactly. It's a multi-layered control system designed for both precise regulation and safety.
Okay, we've got the hormones made, transported, activated, and the whole system regulated. Now, the big question, how do they actually work inside the cells? What do they do?
Right. What are the mechanisms of action? First, remember they need those transporters like MCT8, MCT10, OADP1C1 to get into the target cells.
Got it. Once inside.
The primary way thyroid hormones, particularly T3, exert their effects is via genomic actions mediated by nuclear receptors.
Nuclear receptors, meaning they affect our genes.
Precisely. T3 travels to the cell's nucleus, its command center. Inside the nucleus, it binds to specific proteins called thyroid hormone receptors, or TRs. These TRs belong to a large superfamily of proteins that act as transcription factors, essentially, master switches that control gene expression.
Are there different types of these TR switches?
Yes, in humans there are two main genes, THRA and THRB, which produce different TR isoforms. TREA, from THRA gene, is highly expressed in tissues like the heart and skeletal muscle. It seems to be the main mediator of thyroid hormones' effects on the heart. TREO, from THRB gene, has a couple of forms. TREO1 is found widely in the brain, liver, and kidney. TR2 is more restricted, found mainly in the pituitary, hypothalamus, cochlea, inner ear, and retina.
TR2 in the pituitary and hypothalamus, that sounds familiar. Is that involved in the feedback loop?
Exactly. It's primarily T3 acting via TR2, the pituitary thyrotropes and hypothalamic TRH neurons, that mediates the negative feedback, suppressing TSH and TRH gene expression.
Ah, okay. So how does binding T3 to these receptors actually switch genes on or off?
It's quite elegant. The TR usually partners up with another nuclear receptor called the retinoid X receptor, RXR, forming a heterodimer. This TR-RXR pair binds to specific DNA sequences near target genes, called thyroid response elements, TREs. Now, in the absence of T3, this TR-RXR pair often recruits other proteins called co-repressors. These co-repressors put a brake on the gene, inhibiting its baseline activity.
So no T3 means the gene is silenced or slowed down.
Right. But when T3 comes along and binds to the TR, it causes a shape change. This shape change kicks off the co-repressors and instead recruits a different set of proteins called coactivators. This whole complex, now with T3 and coactivators bound, actively promotes the transcription of the target gene, turning it on or ramping up its activity.
So T3 binding flips the switch from brake to accelerator for specific genes.
That's a great way to think about it. This mechanism explains how thyroid hormone can control the production of so many different proteins involved in metabolism, growth, and development.
Does this ever go wrong, like mutations in the receptors?
Yes, that leads to thyroid hormone resistance syndromes. These are typically caused by inactivating mutations in the TR genes, most commonly TR.
So the receptor doesn't respond properly to T3.
Correct. If the resistance is primarily due to faulty TR2 in the pituitary and hypothalamus, the negative feedback loop is impaired. The pituitary doesn't see the thyroid hormone properly, so it keeps secreting TSH even when T4 and T3 levels are high. You get high T4, T3, but inappropriately normal or even high TSH.
But what about the rest of the body? Do the other tissues respond to the high hormone levels?
Often, yes. If the chemoreceptors in peripheral tissues like the heart are still working fine, the patient might actually show signs of hyperthyroidism, like rapid heart rate, because those tissues are responding to the excessive hormone levels, even though the pituitary feedback is broken.
That's complex. Does understanding these different receptors offer therapeutic potential?
Definitely. Researchers are actively working on developing drugs called TRO-specific agonists. The idea is to create a molecule that activates TR, which is involved in beneficial things like lowering cholesterol in the liver, but doesn't activate TR, which mediates potentially harmful effects on the heart rate. It's a targeted approach.
Very interesting. Now, you said this nuclear receptor mechanism is the primary way. Are there other ways thyroid hormones act?
Yes, there's growing evidence for what are called non-genomic actions. These are effects mediated by T3 or even T4 interacting with receptors or proteins located outside the nucleus, in the cell membrane, in the cytoplasm, or even in the mitochondria.
And these are faster.
Generally, yes.
Yeah.
They don't involve the relatively slower process of changing gene transcription. Examples include reports of truncated forms of TIA acting at the cell membrane in bone cells, or T4 binding to proteins in the cytoplasm to regulate the cell's internal skeleton. There's even evidence that a protein called integrin alpha-3 on the cell surface can act as a T4 receptor to influence cell proliferation.
So a mix of slow gene-level changes and potentially faster, more immediate effects.
Exactly. How these classical genomic actions and these emerging non-genomic pathways interact and coordinate is still a really hot area of research.
Yeah,
It adds another layer to the hormone's versatility.
it really does. Okay, so now we understand how it works. Let's get into the what. What are the major physiological effects across the body? It seems like it touches almost everything.
It pretty much does. Thyroid hormone acts on virtually all cells and tissues. That's why thyroid imbalances are so common and have such widespread symptoms. And remember, it often acts in a permissive way. It doesn't just do things directly, but it also primes tissues to respond better to other hormones, like adrenaline or growth hormone.
Okay, let's walk through some key systems. The cardiovascular system seems like a big one.
Huge. T3 has major effects here, primarily aimed at increasing cardiac output, making the heart pump more blood to meet the body's increased metabolic demands. It increases resting heart rate, positive chronotropy. It increases the force of contraction with each beat, stroke volume, positive inotropy, and it even speeds up how quickly the heart muscle relaxes between beats, positive lusitropy.
Faster, stronger, quicker relaxation.
Right. This leads to a modest increase in systolic blood pressure, the top number, but often a decrease in diastolic blood pressure, the bottom number.
Why?
How's a decrease in diastolic? Because T3 also causes vasodilation, it relaxes the smooth muscle and peripheral arterioles, especially in the skin, muscle, and heart. This reduces systemic vascular resistance, SCR.
So the heart pumps harder, but the pipes it's pumping into are wider.
Exactly. That combination leads to that widened pulse pressure, the difference between systolic and diastolic you often see in hyperthyroidism. T3 even increases total blood volume slightly by activating systems that retain sodium and water.
How does it make the heart contract stronger?
Through multiple mechanisms, both direct and indirect. Directly, T3 regulates the genes for key heart muscle proteins. For example, it increases the expression of faster myosin heavy chains and proteins involved in calcium handling within the muscle cells, like circuit pumps and ryanodine receptors, making contractions more forceful and relaxation quicker. Indirectly, it makes the heart more sensitive to catecholamines, like adrenaline.
So clinically, low thyroid function means
Reduced cardiac output, slower heart rate, less efficient pumping. The increased SVR might also contribute to heart strain.
and high thyroid function.
Increased cardiac output, rapid heart rate, tachycardia, that widened pulse pressure. Thyrotoxicosis puts a significant strain on the heart.
Okay, heart effects are clear. What about metabolism, the basal metabolic rate, BMR?
Thyroid hormone is the major regulator of BMR and overall thermogenesis, heat production. It cranks up the metabolic furnace, it increases oxygen consumption by most tissues, and it affects the metabolism of all major fuel sources.
Like what?
Glucose. It enhances glucose absorption from the gut, increases glucose uptake by cells, glucose oxidation, burning, and also glucose synthesis, gluconeogenesis. Basically, it speeds up glucose turnover, lipids. It stimulates both fatty acid synthesis and lipolysis, fat breakdown. It enhances the clearance of fats from the blood. It accelerates overall lipid turnover, protein. It increases protein turnover too, both synthesis and degradation, with often a net breakdown effect, especially in muscle if levels are too high.
So it speeds everything up.
Pretty much. It potentiates the effects of other metabolic hormones like adrenaline, glucagon, cortisol, and growth hormone, amplifying their effects on breaking down fuel stores. Someone aptly described its overall metabolic effect as accelerating the physiological response to starvation.
Huh. What about cholesterol?
That's a key one. Thyroid hormone stimulates the liver to convert cholesterol into bile acids and promotes their secretion. This leads to a decrease in the body's total cholesterol pool and specifically lowers plasma levels of LDL cholesterol, the bad cholesterol.
So hypothyroidism often means high cholesterol?
Very commonly, yes. And hyperthyroidism tends to lower it. It also increases the metabolic clearance, the breakdown rate of other hormones like steroids, and even some vitamins and drugs.
Okay, and the heat production part, thermogenesis.
T3 stimulates heat production in a couple of ways. One way is by increasing ATP utilization. It ramps up energy-consuming processes like the NAP plus K plus AT-PACE pump and calcium cycling in muscle, circuit pumps. These processes are inherently inefficient, and some energy is lost as heat. The other way involves brown adipose tissue, BAT, or brown fat.
Brown fat. I thought that was mainly in babies.
It's more abundant in babies, yes, but adults retain some, especially in certain areas like around the neck and chest. And it seems more active in lean individuals and when exposed to cold. Brown fat is specialized for heat production. It contains a unique protein called uncoupling protein 1, UCP1, or thermogenin. UCP1 essentially short-circuits the mitochondrial energy production process, dissipating the energy directly as heat instead of making ATP.
And thyroid hormone is involved.
Yes. UCP1 expression is regulated by thyroid hormone. Plus, brown fat expresses high levels of that D2 deiodinase, allowing it to make lots of active T3 locally. There's a strong synergy here between thyroid hormone and the sympathetic nervous system, adrenaline. Adrenaline stimulates fat breakdown in BT. T3, in turn, makes BT more sensitive to adrenaline. The combination powerfully drives heat production.
Which explains the temperature intolerance.
Exactly. Hyperthyroidism leads to heat intolerance and excessive sweating. Hypothyroidism leads to cold intolerance and decreased sweating.
Makes sense. What about breathing? Respiratory effects?
Since T3 increases oxygen consumption, it also stimulates processes to enhance oxygen delivery. It increases the resting respiratory rate and minute ventilation. It also enhances the ventilatory responses to high CO2 and low O2, helping to keep blood gases normal despite the higher metabolic rate. It might even slightly increase red blood cell production via erythropoietin, boosting oxygen carrying capacity.
And skeletal muscle?
Oxygen use is up. In hyperthyroidism, muscle energy stores like glycogen can be depleted. There can also be issues with creatine metabolism, leading to muscle weakness and wasting in severe cases.
You mentioned synergy with the autonomic nervous system before.
Yes, particularly with the sympathetic nervous system and catecholamines, adrenaline and noradrenaline. Many symptoms of hyperthyroidism, like the rapid heart rate, tremor, nervousness, and increased metabolism, resemble a state of sympathetic overdrive. Part of the mechanism seems to be T3 increasing the number of beta-adrenergic receptors, the receptors adrenaline binds to, in tissues like the heart, making them more sensitive.
Okay. A really critical role is in growth and maturation, right? Especially early in life.
Absolutely fundamental. Thyroid hormone is essential for normal growth and development, particularly of the skeleton in the brain. Even before birth, a small amount of maternal thyroid hormone crosses the placenta, and the fetus's own thyroid axis starts working around mid-gestation. This prenatal and early postnatal period is a critical window. Thyroid hormone deficiency during this time leads to congenital hypothyroidism.
We talked about that irreversible intellectual disability and stunted growth if not treated.
Correct. It highlights the hormone's crucial role in brain development. Things like nerve cell growth, branching, synapse formation, myelination, all critically dependent on T3.
And effects on bone later in life.
It continues to be important. T3 promotes normal bone growth, maturation of growth plates, and bone remodeling throughout life. It influences chondrocytes, cartilage cells, in the growth plates. It works alongside growth hormone and other factors to ensure proper linear growth during childhood and adolescence. Even tooth development and eruption depend on it.
What about skin, hair, nails?
Also regulated. Normal cycles of growth and maturation of the epidermis, hair follicles, and nails require thyroid hormone. Both too much and too little can cause problems like hair loss, dry skin, or abnormal nail formation. It also affects the structure of the subcutaneous tissue by regulating the breakdown of certain molecules like glycosaminoglycans. An imbalance here contributes to the myxedema seen in hypothyroidism.
And the nervous system in adults, beyond development.
Yes, it continues to influence CNS function throughout life. It enhances wakefulness, alertness, responsiveness, hearing, memory, and learning capacity. Normal emotional tone also depends on having the right amount of thyroid hormone. Too little leads to slowed thought, lethargy, depression. Too much causes anxiety, nervousness, irritability, rapid thoughts. It also affects peripheral nerves, increasing the speed and amplitude of reflexes, and it influences gut motility.
Lastly, reproductive function and other endocrine glands.
Thyroid hormone plays an important permissive role here. Normal reproductive function in both women, menstrual cycles, pregnancy, and men, spermatogenesis, requires normal thyroid levels. Deviations can disrupt these processes. Part of this might be due to alterations in the metabolism or binding of sex steroid hormones. For instance, T3 stimulates the liver to produce sex hormone-binding globulin, SHEGG.
Does it affect other hormones directly?
It influences pituitary hormones, can increase growth hormone, decrease prolactin. It affects adrenal function, stimulates cortisol secretion, but also increases its clearance, so free cortisol levels usually stay normal. It can alter the balance of sex steroids. It impacts calcium regulation indirectly via effects on bone. And it influences kidney function, increasing renal blood flow and filtration rate.
Wow. It really is involved in almost everything. It's not just a regulator. It's like a fundamental architect of how our bodies function daily.
That's a perfect way to put it. It sets the pace, tunes the responsiveness, and supports the structure and function of nearly every system. Understanding this scope is key to understanding thyroid disorders.
Absolutely. Which brings us to the clinical side. We understand the normal function now. What happens when it goes wrong, and how do we assess it?
Right. Clinically assessing thyroid function is crucial. We talked about TSH, T4, T3 levels. Another common test is the radioactive iodine uptake, RAIU.
Remind us how that works again.
It leverages the thyroid's unique ability to trap iodine. You're given a tiny, harmless dose of radioactive iodine, usually iodine 123. A detector placed over your neck then measures how much of that tracer the thyroid gland takes up over time, typically at 4, 6 hours, and 24 hours.
Yeah, and the results tell you
how active that iodide trap, the NIS pump, and subsequent processing are. In the U.S., typical uptake might be 15% at 6 hours, 25% at 24 hours. If the uptake is abnormally high, say 60% at 24 hours, it suggests an overactive gland hyperthyroidism. If it's abnormally low, 5%, it suggests an underactive gland hypothyroidism, or perhaps that the gland is already full of iodine or blocked by medication.
You mentioned Graves' disease having a specific pattern.
Yes, in Graves's, the turnover is so rapid that the 6-hour uptake might be very high, but the 24-hour value might be lower than expected, or even normal, because the trapped iodine is quickly made into hormone and released.
Interesting. Can the RAIU test reveal other problems?
It can suggest an organification defect, meaning the thyroid traps iodine okay, but can't properly incorporate it into thyroglobulin. Certain drugs can block iodide transport, and giving them during an RAIU test can cause a rapid washout of trapped iodide if organification is blocked.
Okay. What about imaging the thyroid directly?
Thyroid imaging is also very important. This can be done with similar radioactive tracers, like iodine 123, iodine 131, or technetium-99 meter protectatate, using a scanner or gamma camera. We also use ultrasonography extensively and sometimes MRI.
What does imaging show you?
It shows the size and shape of the gland, and crucially whether activity is uniform or if there are areas that are more or less active than others, like nodules.
Thyroid nodules, are they common?
Very common. They often represent areas where follicles have gone through cycles of stimulation and then regression. On scans using radioactive tracers, nodules can be classified as hot or cold. Hot nodules show high tracer uptake, meaning they are actively trapping iodine, sometimes excessively. They're usually benign but can occasionally cause hyperthyroidism, toxic nodule. Cold nodules show decreased tracer uptake compared to the surrounding tissue. These are more concerning, about 10 times more likely to be cancerous, though most are still benign.
So cold nodules usually need further investigation.
Yes, typically with a fine needle aspiration, FNA biopsy, where a small sample of cells is taken for examination under a microscope. Ultrasound is excellent for visualizing nodules, measuring their size, checking their characteristics, solid versus cystic, and is invaluable for guiding that FNA biopsy accurately. MRI offers the highest resolution for anatomical detail, but isn't used as routinely for initial nodule evaluation.
Okay, let's talk about the main conditions. Hypothyroidism, not enough hormone.
Right. The first step is usually figuring out where the problem is. Primary hypothyroidism. The thyroid gland itself is failing. Lab tests show low T4 and T3, but the pituitary is trying hard to compensate, so TSH is high. This is the most common scenario. Secondary tertiary hypothyroidism. The problem's higher up. Either the pituitary isn't making enough TSH, secondary, or the hypothalamus isn't making enough TRH, tertiary. In these cases, T4 and T3 are low, and TSH is also low or inappropriately normal. Specific tests using synthetic TRH can sometimes help distinguish pituitary from hypothalamic causes.
And the most severe form occurs early in life.
Yes, congenital hypothyroidism. If a fetus or newborn doesn't have sufficient thyroid hormone, the consequences for brain and skeletal development are devastating and irreversible if not treated promptly.
Symptoms being
severe intellectual disability, short stature, coarse facial features, enlarged tongue, historically called cretinism.
What causes it typically?
Worldwide, the most common cause historically and still in many areas is severe maternal and fetal iodine deficiency. Thankfully, this is largely preventable with public health measures like iodized salt. Less common causes include congenital defects where the thyroid gland doesn't form properly, dysgenesis, genetic mutations in the hormone synthesis pathway affecting NIS, TPO, thyroglobulin, pendrin, etc., or rare blocking antibodies against the TSH receptor passed from mother to baby.
Treatment timing is critical.
Absolutely. The severity of the developmental defects is directly related to how early diagnosis is made and T4 replacement therapy is started. Treatment within the first few weeks of life can allow for near-normal cognitive development. Delay, even by a few weeks, leads to permanent impairment.
Which is why newborn screening is so important.
Essential. Babies often look normal at birth because they had some maternal hormone. Screening blood spots for T4 and/or TSH shortly after birth catches it early.
Okay, what about adult hypothyroidism in areas without iodine deficiency?
The most common cause by far in iodine-sufficient regions is Hashimoto's disease, also called Hashimoto's thyroiditis.
That's autoimmune, right?
Yes. The body's immune system mistakenly attacks the thyroid gland. Antibodies are often produced against thyroglobulin and thyroid peroxidase, TPO. The gland becomes infiltrated with lymphocytes, immune cells, which can initially cause enlargement, goiter, but eventually leads to destruction of thyroid tissue and failure to produce hormones.
What are other causes in adults?
It can be iatrogenic, meaning caused by medical treatment, like damage from radioactive iodine therapy used to treat hyperthyroidism or surgical removal of the thyroid. Long-standing nodular goiters can sometimes burn out. Pituitary or hypothalamic diseases can cause secondary tertiary hypothyroidism, and certain drugs can interfere. Amiodarone, a heart medication, is a classic example, as it contains a huge amount of iodine and can cause either hypo or hyperthyroidism.
And the symptoms in adults. We touched on them, but let's recap.
They're often insidious, developing slowly.
Yeah.
Basically, everything slows down. Lower metabolic rate and weight gain, fatigue, low energy, decreased thermogenesis, cold intolerance, dry skin, decreased sweating, neurological, slowed thinking, brain fog, slow speech, lethargy, sleepiness, depression, sometimes carpal tunnel syndrome due to tissue swelling, droopy eyelids, cardiovascular, slow heart rate, bradycardia, reduced cardiac output, high cholesterol, myxedema, that characteristic non-pitting puffiness, especially face, hands, feet, caused by accumulation of glycosaminoglycans in the dermis, attracting water, can cause hoarseness, joint stiffness, effusions, fluid, and body cavities. Other common ones: constipation, hair loss, often coarse hair, menstrual irregularities in women, anemia.
Treatment is generally effective.
Very. Standard treatment is daily oral replacement with synthetic T4, levothyroxine. The dose is adjusted based on TSH levels, aiming to bring TSH back into the normal range.
Why not T3?
Usually not necessary because the body can convert the T4 into T3 via those deiodinases, D1 and D2. Giving T3 directly is tricky because it's much more potent and has a shorter half-life, making it hard to maintain stable physiological levels without causing spikes and dips. Most patients do perfectly well on T4 alone.
Okay, that's hypo. Now for the flip side, hyperthyroidism, too much hormone.
Right, the state of excess thyroid hormone is called thyrotoxicosis. The most common cause of this is Graves' disease.
Also autoimmune.
Yes. But in Graves', the immune system produces activating autoantibodies against the TSH receptor. These antibodies, often called thyroid-stimulating immunoglobulins, TSIs, mimic TSH and constantly stimulate the thyroid gland to grow and produce excessive amounts of T4 and T3, independent of the normal feedback control.
So the thyroid is basically stuck in the on position.
Exactly. This usually causes a diffuse goiter. The whole gland is enlarged and overactive. Under the microscope, the follicular cells are large and hyperactive, and the colloid often looks scalloped at the edges, indicating it's being rapidly broken down and released.
Who gets Graves' disease?
It's much more common in women, 5-10 times more, and typically occurs between the ages of 20 and 50.
And the symptoms of thyrotoxicosis, they sound like the opposite of hypothyroidism.
Pretty much. Everything speeds up, often dramatically. High metabolic rate leads to weight loss despite increased appetite and food intake. Thermogenesis, excess heat production, causes heat intolerance, excessive sweating, increased thirst. Neurological enhanced sympathetic activity leads to rapid heart rate, tachycardia, tremors, especially in hands, hyperkinesis, restlessness, nervousness, anxiety, irritability, insomnia, often a characteristic wide-eyed stare, emotional lability, musculoskeletal muscle weakness and fatigue, often due to increased protein breakdown and impaired muscle function, respiratory shortness of breath, especially with exertion. If the goiter is large, it can cause difficulty swallowing or breathing. Cardiovascular sinus tachycardia is very common. Increased cardiac output, palpitations, sometimes atrial fibrillation, that widened pulse pressure we discussed.
And the eye changes. Exophthalmos.
Yes, exophthalmos, protrusion of the eyeballs, and periorbital edema, swelling around the eyes, are common and specific signs of Graves' disease, part of what's called Graves' ophthalmopathy or orbitopathy. It's also caused by the autoimmune process. Those same TSH receptor antibodies, and potentially antibodies against other orbital antigens, bind to receptors on fibroblasts and fat cells behind the eye. This triggers inflammation, increased production of glycosaminoglycans like hyaluronic acid, swelling of the eye muscles, and expansion of orbital fat, pushing the eyeball forward.
So the eye disease is part of the same autoimmune attack. How is Graves diagnosed?
Usually by the combination of clinical signs, thyrotoxicosis symptoms, diffuse goiter, ophthalmopathy, and lab tests showing high free T4 and T3 with a suppressed, very low TSH level because the pituitary is trying to shut down the overstimulated thyroid. An RAIU scan typically shows high diffuse uptake. Testing for the TSH receptor antibodies, TSI, can confirm the diagnosis.
In treatment.
Options include antithyroid drugs, like methimazole or propylthiouracil, that inhibit the TPO enzyme, blocking hormone synthesis. Another option is radioactive iodine therapy, iodine-131, to ablate or destroy the overactive thyroid tissue. Surgical removal of the thyroid, thyroidectomy, is also sometimes used.
Okay. One last condition you mentioned earlier, non-thyroidal illness syndrome, NTIS.
Right, also called euthyroid 6 syndrome. This isn't a primary thyroid disease itself, but rather changes in thyroid hormone levels that occur during severe acute or chronic systemic illness, like sepsis, major trauma, surgery, or starvation.
What happens to the hormone levels?
Typically, you see low levels of circulating T3, often low or low normal T4, and paradoxically, TSH is usually low or inappropriately normal, not elevated as you'd expect with primary hypothyroidism.
Why does that happen?
It seems to be a centrally mediated suppression of the HPT axis. The hypothalamus reduces TRH production, leading to reduced TSH. Plus, peripheral metabolism shifts. There's reduced conversion of T4 to active T3, likely decreased D1 and D2 activity, and increased conversion of T4 to inactive reverse T3, RT3, by D3 deiodinase. There can also be alterations in hormone binding to transport proteins.
Is it beneficial, this shutdown during illness? Should it be treated?
That's the big debate. It might be an adaptive response to conserve energy during critical illness. The clinical utility of giving thyroid hormone replacement to these patients is controversial and generally not recommended unless there's clear evidence of underlying primary hypothyroidism.
Fascinating. It really shows how interconnected thyroid function is with overall health and stress responses.
Absolutely. And understanding these conditions, from Hashimoto's and Graves to congenital hypothyroidism and NTIS, really stems directly from understanding that fundamental physiology. You've covered the synthesis, the regulation, the transport, the action. It all links together.
We have certainly gone deep today, traveling through the entire world of the thyroid gland. From those tiny follicle factories, the intricate steps of hormone synthesis and recycling, the journey through the bloodstream, the crucial activation by deiodinases, all the way to the precise feedback loops involving the hypothalamus and pituitary, and the hormone's ultimate action on nearly every cell via nuclear receptors and maybe other pathways too. We aimed for that professional-level conceptual grasp, and hopefully we've helped you build that understanding.
Yeah, I think connecting all those dots really helps appreciate the bigger picture. You see how this one small gland is just fundamental to development, growth, metabolism, brain function. Its influence is truly immense. Mastering this information really illuminates the body's interconnectedness.
It absolutely does. So here's a final thought to mull over. Given everything we've learned about the thyroid's critical role, its complex regulation, the importance of transport and activation, what might this imply for future approaches to health and wellness? Could we move beyond just replacing T4 and think more about personalized strategies, maybe focusing on optimizing iodine status, supporting those deiodinase pathways, or even ensuring efficient cellular transport, really tailoring support to the individual's specific physiology? Something to consider. Until next time, keep diving deep into what makes us tick.